Welcome to The Explainer. Today, we're breaking down a really critical component of trauma care from the ATLS manual, Chapter 5, which is all about breathing and ventilation. So you've got the airway open, but now what? We've got to make sure the patient can actually use it. I think this quote from the manual says it all. Airway patency alone does not ensure adequate ventilation. It's so easy to check A off the list and move on, but that's a huge mistake. Just because there's an open road doesn't mean traffic is moving. This single sentence, really, it sets the stage for everything we're about to cover. So, here's our game plan. We're going to walk through why B, for breathing, is the crucial second step. Then we'll cover how to do a lightning-fast thoracic assessment. After that, we'll zero in on the immediate life threats you absolutely cannot miss, and of course, the critical interventions to fix them. And finally, we'll touch on how this all changes for special patients. Let's jump in. Okay, Section 1, breathing, the second step. So, why does B come right after A? Well, once you've cleared the airway, your absolute #1 priority is to make sure the patient is actually moving air in and out. It's that simple. A is the highway, but B is the engine making the car go.
And here's the thing, we're talking about more than just the lungs. Effective gas exchange is a whole mechanical system. The lungs, the chest wall, the diaphragm, they all have to work in perfect concert. If any one of those parts is broken, say the ribs are fractured, the diaphragm is ruptured, or the pleural seal is broken, the whole system just fails. No air moves, and that's a huge problem.
All right, next up, the rapid thoracic assessment. This is all about your eyes, your ears, and your hands. So how do we figure out if that mechanical system is broken? Well, it all starts with a super fast but thorough physical exam. We've got to get that chest completely exposed and use our most fundamental clinical skills. And this exam is as simple as look, listen, and feel. So first, you inspect. What are you looking for? Big things. Asymmetrical chest movement. Any penetrating wounds. Maybe some paradoxical motion that screams flail chest. Then you auscultate. Are breath sounds present and equal? Or are they decreased? Or worse, totally absent on one side? And finally, you palpate. You're feeling for tenderness, any obvious deformities, and that telltale crackling of crepitus. This all happens in a matter of seconds. Now, to do this right, you have to know your anatomy cold. These landmarks are absolutely critical. The nipple line gives you a rough idea of the fourth intercostal space, but, the inframammary fold, or IMF, is often a much more reliable landmark for that fifth or sixth rib area. And why does that matter? Because that's your safe zone for things like needle decompression. Then you've got the cardiac box. A penetrating wound there, that's a code red, high-risk injury until proven otherwise. Okay. This right here is the heart of the matter, identifying the immediate life threats. These are the can't-miss diagnoses. This is what the whole rapid assessment is for, to find the handful of injuries that will kill your patient in minutes if you don't spot them. And #1 on that list is the tension pneumothorax. So what's happening here? Basically, an injury creates a one-way valve. Air gets sucked into the pleural space with every breath, but it can't get out. The pressure just builds and builds, first collapsing the lung, and then, and this is the killer part, it shoves the entire mediastinum over, kinking the great vessels and stopping blood from getting back to the heart. It's a double whammy, a breathing problem and a circulation problem. So how do you spot it? Look for this classic triad: severe respiratory distress, shock, so hypotension and tachycardia, and absent breath sounds on the affected side. You might also hear hyperresonance if you percuss. Now, that tracheal deviation you read about, forget about it. That's a super late sign. If you're waiting for that, you've waited way too long. And if you need a reminder of how serious this is, just look at this number. Up to 19% of patients who die after blunt trauma have a pneumothorax. And here's the really scary part. A simple, stable pneumothorax can turn into a deadly tension pneumo in a heartbeat, especially if you put them on a ventilator or even start bagging them. That positive pressure can literally force air into that one-way valve and create the tension right in front of your eyes. Okay, next up is a massive hemothorax. The name says it all. We're talking about a rapid accumulation of more than 1,500 milliliters of blood inside the chest. The patient is literally bleeding out into their own chest cavity. So again, it's that deadly combination, a breathing problem because the blood is collapsing the lung, and a massive circulation problem because they're in profound hemorrhagic shock. And the signs here are pretty distinct. Again, you're going to see shock, but when you listen, you'll hear absent or decreased breath sounds. And here's the key difference. When you percuss, it's going to be dull.
Think about it. The chest is full of blood, not air. So it's the exact opposite of the hyperresonance you'd find in a tension pneumo. Oh, and their neck veins? They'll be flat, because all the volume is in their chest, not their vessels. And the last of the big 3 immediate life threats is the open pneumothorax, what you might have heard called a sucking chest wound. The physics here are brutally simple. If you have a big hole in the chest wall, air is going to take the path of least resistance. Instead of going down the trachea and into the lungs, it's just going to go in and out of that hole. The lung on that side just can't inflate. It's totally ineffective ventilation.
All right, section 4, critical life-saving actions, the fix. Identifying these killers is only half the battle. Now you have to act, and you have to act immediately.
So the question is on the screen. You've diagnosed a tension pneumothorax. What now? And the answer has to be instantaneous. There is absolutely no time to wait for an X-ray. Let me say that again. Do not wait for imaging. This is a clinical diagnosis, and the treatment must be immediate. The X-ray is just to confirm what you've already done. And here's the fix. Immediate needle decompression. You grab a large bore needle, and you've got 2 main spots. Either the second intercostal space at the mid-clavicular line, or, and this is often preferred now, the 5th intercostal space at the anterior axillary line, right around the IMF. You go in right over the top of the rib, always over the top to avoid that neurovascular bundle running underneath. And then you listen for that hiss, that rush of air. It's truly one of the best sounds in medicine. And remember, this is a temporary fix. You've got to follow it up with a definitive chest tube.
So, we've got the basics down. But as always, not all patients are the same. It's absolutely crucial to know how to adapt your approach for special populations, because their anatomy and physiology can really change the game. Let's look at 2 perfect examples, pregnant patients and kids. In a pregnant patient, that growing uterus shoves the diaphragm way up. So what does that mean for you? It means you have to place your chest tube 1 or 2 rib spaces higher than you normally would, or you risk going into the abdomen. Now, with pediatric patients, it's a different story. Their chest wall is super pliable, almost like cartilage, so they can have a massive, life-threatening pulmonary contusion, a bruised lung, without a single broken rib. The absence of fractures means absolutely nothing.
Okay, let's wrap this up with the key takeaways. Number 1, a patent airway does not guarantee ventilation. You have to check. 2, your rapid thoracic exam, inspect, auscultate, palpate, is everything. 3, you must immediately recognize and act on those life threats like a tension pneumo. 4, decompress based on what you see and hear, not on an X-ray. And 5, always adjust your technique for pregnant and pediatric patients. These 5 points, this is the foundation for managing B for breathing.
So that brings us to our final question. Your patient's breathing is now stabilized. What's the next immediate threat you're looking for? Well, by managing A and B, you've bought your patient precious time. You've earned the right to move on and hunt for the next killer, the next step in the ATLS protocol, C for circulation.